Dana Richardson is our next speaker, and Dana is an RN and an MHA. She's Director of PCPI Operations, and we thank her very much for joining us today.
How do I move the slides?
Let's see.
This one, probably?
Looks like next.
Okay.
The green one.
Great. Good morning, and thank you for having me. Just to give you a little bit of background, I do work for the AMA in a program called the Physician Consortium for Performance Improvement. You can't say that 3 times fast either. So we just call it PCPI. The PCPI is a program that has about 190 member organizations right now. So nearly all of the medical specialty societies, most of the state societies, many of the healthcare professional organizations, so nursing, ophthalmology, optometry, others like that, belong to the PCPI. We have government members, so ARC and CMS are members. We have large improvement organizations like IHI, et cetera. So we're really a group of people who work together to improve care. And the work that we've done to date over the past probably 10 years is really to focus on the development of performance measures at the physician level. So at this point, we have about 290 performance measures that we've created. And they cover about 45, 50 different topic areas. We've created a lot of the frameworks that are used by other organizations to develop physician-level measures. So that's kind of a little bit of the background of what PCPI is. The way we got into this registry business is because when we talk to our members about the performance measures, most of which at this point are process measures, but we wanted to move into outcome measures, and we said, well, where would the data come from? I mean, if we want to develop national level outcome measures that are going to be used in government programs and quality improvement programs and all these other ways that our current measures are used, where would the data come from in a systematic way? So as we talked to our members that had registries, they said, well, we have a registry. That's where we would get our data. But they also said to us, but we have certain issues that we have with our registry. So we are having trouble standardizing our data elements. We're having difficulty moving into an automated world. Hopefully this is sounding familiar to you now, since you've heard this morning these are a lot of your same challenges as well, to which they said, couldn't the PCPI do something to help coordinate the work of registries? So that's really the perspective from which I'm going to talk about today. So we have been working on a concept called the National Quality Registry Network. And the network would really be a network that your registry organization, that you as a society could participate in to learn from other organizations that already have or are creating registries to help hopefully solve your problems quicker. So that's the idea. So I'm going to give just a very brief overview of the landscape of registries. I'm going to talk a little bit about the NQRN because this is a very new initiative. So I only have so many slides to give you at this point. And then if we want, we can take questions at the end. So there are lots of different kinds of registries out there. There are registries for transplant and surveillance, and there's device registries, and there's pharmaceutical registries. But what we're really focusing our efforts on at this point, starting out, are the clinical registries. So registries like yours, those that are being developed to drive quality improvement, perhaps comparative effectiveness research, those types of tools. I'm not going to talk about the impact of registries because you're already into this business. You've already, I guess, drank the Kool-Aid. You understand that registries have a value, particularly in performance improvement, by providing information back to the practitioners at the point of care. But there are more and more published works out there that have been able to demonstrate the value of registries and how they are improving care. And we have spent a fair amount of time looking at the Swedish registry system because they do have a coordinated national system of registries in Sweden that actually started out very much like the United States, with individual registries kind of coming up and then eventually kind of connecting and getting organized. There is a lot of interest in the registries at the federal government level. We just had a presentation by the FDA, but we also know that in the PQRS world, they've now are accepting data from registries, so we have several registries that are out there in part for that purpose. We know that there is the ability to use that same registry data to meet some of your meaningful use criteria. We've seen registries talked about in the ACO programs, because how are ACOs going to be able to measure their worth, I guess, which is part of what they're going to have to do under the ACO payment model. And of course, ARC has done a lot of work in registries, both in developing the user manuals, but also the registry of patient registries. So our goal is not to necessarily compete with any of these things that are going on, but to see how can we be a coordinating body for all of these various activities. Today we know, at least from the perspective of the clinical registries, that there are about 20 to 25 organizations, although I periodically am still learning of a new organization like yours that is bringing together a registry, and we believe there are 50 to 60 clinical registries out there today. However, when we did a gap analysis and we said if we mapped these registries, and this included all of the cancer registries and others, that's why the numbers are so high. If we mapped it to some of the national priorities by cost and, and leading causes of mortality, you can see that there are some significant gaps. So while we have many registries in the cancer area, although they are a network, so that 94 is a little bit deceptive, and we have a lot of registries that relate to heart disease. We have no registries, for example, in mental illnesses related to depression, which is clearly a national priority. So we know that there are gaps out there, and one of our priorities is really to see if we can incent the development of registries in some of these key gap areas. So the primary purpose of the National Quality Registry is really to address some of the issues that have been brought forward to us by our members, by those of you who have registries. We know that people struggle to develop a viable business model. I mean, these are expensive endeavors, as you've probably learned. It costs a lot of money to bring up a registry, but it costs money to keep them going. So what is the business model going to be for that? Could there be some incentives, perhaps, that would help practitioners to pay for participation in the registry? How do you select a vendor? How do you bring your data on electronically? How do you design the best feedback reports, and how often should they be provided? We do have registries today that are essentially providing data on a real-time basis. So you're kind of at a situation where you're at a 6-month basis, looking to bring that down to a quarterly. There are registries that are now moving into a almost real-time feedback loop. So there's some advancements that we think that some registries have been able to identify in certain areas that perhaps an organization like yours could learn from. So in order to get into this work, we have been working with a multi-stakeholder group. I'll show you in just a minute who they are. But we held a meeting in July of 2011 where we presented the concept of the NQRN. It was a multi-stakeholder group. We said, you know, what do you think about the concept? Is this something that would be of value? What we heard is, yeah, we think it would be of value, but we need to figure out what we really need to do here. So then we put together a task force. We worked with the task force for about 4 months on a recommendation that was presented in November. And since that point in time, we've really been working on bringing up a governance structure and figuring out what will we be doing in the next couple of years. So the NQRN is a voluntary network of private and public registry stewards and other stakeholders that are interested in advancing the development and the use of registries to evaluate and improve patient outcomes. So I think it fits pretty nicely with the work that you're doing. This is really the model that we would like to aspire to. So we believe that through shared services, through standardization, and through coordination of efforts, we can advance registries much more quickly than has been the case for some of those who have been out there for several years. So for example, the STS registry that was talked about in the initial presentation here today has been out there for over 20 years. And they said to us, it should not take 20 years for every other registry to get to the point where we are. We should be able to help move this along because, frankly, we don't have 20 years anymore. They had the luxury of time, which we don't all have at this point. So this is our steering committee. It is a multi-stakeholder steering committee. David Shahian is with the STS. He co-chairs this with Lou Sandy, who is from United Healthcare. So we have a lot of participation from registries, but we also have consumer representatives from Consumer Reports. We have health plans that are interested in this. And then we do have the federal government that is also participating in our steering committee. Beyond the steering committee, we have put together what's called the council. The council, again, is a multi-stakeholder group. And the idea is that by bringing together the interest and the needs of the multiple stakeholders, that we'll be able to work towards, again, a future that meets these multiple needs a little bit quicker over time. So our goals are to reduce the time that it takes to develop a registry and to get every registry to a point where we can say these are high-quality registries. Because what we believe we have today is really a spectrum of maturation. So we've got those like the SDS and the Cystic Fibrosis Registry that have been out there for years. And they've had a lot of time to develop their quality auditing standards and all these other types of functions. But then we've got registries that are only a few years old, and we've got at least 6 or 7 organizations bringing up registries today for the first time. So how can we bring them all along and get to a point where payers, the government, physicians particularly, and others who use the data or would like to use the data can say, yes, we believe that this is a high-quality registry. So that's a good part of our goal. Hopefully we can reduce your administrative costs as we move forward with that. I talked earlier about identifying these gap areas where we don't yet have registries, but we also would like to make sure that as we move forward, that organizations that are interested in doing some of the more advanced work like public reporting of your data have an opportunity to learn from those who are already doing that type of work. So we think that we will be successful when we have met some of these goals, and particularly, I think out of the box, we need to focus on business models because it costs money to run registries. So now that we have our steering committee in place, we've put our council in place, we've been working with a lot of organizations like yours who are interested in participating in the network. We are working right now on a survey so we can do a deeper dive into where the various registries across the U.S. are, so that we can then develop some programming that we hope will be tailored to the types of interests and needs that you have. So I will stop there.